Hello, everyone, and welcome back to our episode 2 of our Accora Clinical Corner. My name is Nicola Murphy, and I'm an occupational therapist, and I work for Accora. And before we start off, and I introduce you to all my lovely colleagues here, just a few housekeeping. So I believe you're all being put on silence, so that's great. However, if anyone has any questions or comments, please use the chat box to pop in any of your questions, and we can definitely go through all of those. And then I suppose I'll hand you over to Jane. We have Jane, Sarah, and Chris here. So Jane, would you like to introduce yourself?
Yeah. Thanks, Nicola. Hello, everybody. My name's Jane Brewer. I'm an occupational therapist with Accora. I'm part of the clinical team. My background has been mainly as a community occupational therapist in Hertfordshire and Bedfordshire. And then I worked in equipment stores as a clinical lead before joining Accora. So I have a wonderful job at Accora, not only doing podcasts like this, we do lots of face-to-face training around sort of the clinical benefits of the products, and get involved in doing some seating assessments and doing some clinical trials with the new pieces of equipment that we bring out.
Hi, my name's Sarah Thompson and I am a tissue viability nurse. Same as Jane, part of the clinical team delivering education, and my background is community, acute. I've done a little bit of private work with a wound care company. So yeah, it's great with our role to be able to help our service users and yourselves with education support around all of our products.
Good. Chris Seal, not a clinician, not important enough to be part of of that team. But I was a product specialist in the South East in London for around 6 years. I'm now the account manager for South East in London. So any sort of product related questions, I'll be able to help on today as well.
Brilliant. Thank you so much, everyone. I didn't actually, I suppose, give my experience. So my experience comes through within the NHS. So I've done lots of rotations in and around the NHS. I've had some experience out in the community and then some experience within the wheelchair services as well. And like Jane and Sarah, really enjoy my job, all the different aspects we have, and especially this new, I suppose, aspect to our job. So the podcast, the clinical corner. So we really enjoy getting these tough questions. Don't make them too tough, but please do, as I say, pop the questions into the chat. We do have some pre-questions that were submitted, so we definitely will run through those. And I suppose we want to just highlight what this session is around. So in the last 3 months, in the last quarter, we've done a lot of work. I don't know if you've noticed, but we've done a lot of blog posts, and mostly in and around sleeping in a riser recliner. We've also focused in on sleep hygiene, the comfort of being in a riser recliner, why someone's confidence might impact them and cause them to sleep in a riser recliner, maybe someone's transfers, and then their mobility. Again, we look at pain management through the blog post, and most importantly as well, tissue viability and the impact of someone sleeping in a riser recliner on their skin integrity. We also want to highlight intervention solutions and explore practical strategies for teaching and supporting others. So hence why we've created this tool kit. So at the end of the quarter, we released a toolkit with all these different blog posts and all the webinars that we've done online in and around sleeping in a riser recliner. So today we're here to answer your questions. So we will kick it off. I will test you guys, hopefully. And so I'll be just answering, shooting out the questions to my lovely colleagues here. And the first one up is from a colleague, Jill. So I do hope Jill is out there and we do answer this question well. So Jill has asked us, I have seen swollen legs improve when people use Accora chairs. That takes hips lower than the ankles, but are there any studies to support provisions of chairs where we must justify funding for medical management of legs? Oh,
spicy.
How's your research, Sarah?
So we did look into this a little bit. There's no real in-depth research out there. I think that Jane and I were speaking about this earlier. It's looking at everything as a whole. Obviously, we all know that having your legs above the hip level, above heart level, that will help edema, that helps that venous return. So we do know that, and there will be studies out there for that. But I think it's the whole picture, making sure people have that movement, because it's the edema is down to the movement of the leg, the movement of the calf pump muscle that I was saying about in my webinar in, can't remember, beginning of March. So it's looking at the whole thing. So research is out there in different parts of it, but it's pulling all of those bits together.
You kindly sent your question in advance, so we did have a little look in the background to see if there was any specific research around the reduction of edema in using a riser recliner, and a quick search I couldn't find anything that specific. So it is, again, it's thinking about that bigger picture, that holistic picture, isn't it? To help, just I guess it's for your justification to get a chair. So it's thinking about, you know, those knock-on effects. If you don't elevate the legs, it's going to have a knock-on effect on someone's mobility and things like that.
And if you're getting that reduction of mobility, then you're more at risk of getting pressure damage. It's piecing all of those bits together, that lack of motivation, the poor or lack of productive sleep. It will all add an element that will have part of the edema to the legs.
Yeah, very good. Jill has just had an additional question. So when a person has heavy legs, does the pressure on the underside of legs from elevated leg rests cause restriction of circulation in that area or other concerns?
It can do. So normally when we're talking about this, it's the edematous legs, it is that water. They are so heavy, and often you'll find with these sort of legs, you'll start getting weeping of the legs, and we'll find that you'll get the weeping underneath. You can't necessarily, you can have pressure caused by there, but you've got no bony prominence, so a pressure ulcer as such won't develop. But you can, the circulation as such, you will still you'll still get that circulation, unless you've got peripheral vascular disease and you're elevating them too much. That's when you could have problems with circulation, but you don't normally get peripheral vascular disease with edematous legs. So again, there's lots of different things.
You'll get that sort of marking, won't you? If someone's got like their socks or something, that sort of get that marking.
But circulation wise, no, it's more that the venous return rather than circulation as such.
Yeah, very good. I mean, I think you've done the webinar you did as well. It's very good as well, and explains quite a lot in and around that too. Karen has asked, so in a standard bed, do you also need to elevate legs, and what is the best position for this? I'm assuming that probably would be for edema management as well.
I think just going to bed sorts out the edema kind of for you. It is having that, again, heart level or just above heart level or hip level, but just going to bed your body will sort out that circulation. Your lymphatic system will sort the circulation out just for that, however long you're in bed for.
Would it improve even more though if you ratcheted the leg rest higher? Is that
potentially? I mean, I suppose it would speed it up,
right?
But then you have to take into account, with people we're looking after, things like heart failure, because we don't want to elevate the legs more to then bring more fluid essentially to the heart. And if someone's in heart failure, the heart then can't deal with that.
It's got to work harder, hasn't it, to get drain that.
There's so many things that you need to consider, right?
So
just having that holistic approach. So I would say as well, so as an OT, I would definitely get that advice from my nurse colleagues or the doctors, GPs, etc.
It's the MDT approach. I always used to speak to the heart failure teams, because we can put compression on legs if someone's in heart failure, but you have to do it
is it appropriate?
Very delicately, and you have to do it within a multidisciplinary team approach.
And I think it's knowing that we have those colleagues out there, right, because we don't know everything. It's like in this current job, I for pressure related issues or concerns, I would always go to yourself to ask questions. So
there will be some sort of lymphedema service, won't there? In some areas you could go to them to get that really specialised input. But I think any position that we try and put somebody in, we know will be the gold standard position to help with edema. But it's those other factors. Is that person comfortable in that position? Because they're not going to stay there, are they?
Yeah.
If we raise their legs up and that's, you know, causing tension maybe on their hamstrings or something, they're not going to want to stay there.
Or their lower back. I think we all know that having something to support just under your knee actually takes some pressure off of your lower back. So for comfort, I would always have like a knee brace on and take pressure off of the heels as well.
Yes, yeah. And a lot of people don't know on their beds as well, isn't it? You can have the knee brace, but when you put someone's knee brace, that generally means their ankles are a bit lower. So if you've got that ratchet part on the bed that you can just bring up and bring the legs up level, it just gives a bit more elevation and chance to. That's on all our beds, isn't it, Chris? The ratchet part.
Yeah, probably.
Yeah.
But obviously in a standard bed, we don't have that option. I know you were asking about that, but that's where pillows, blankets, rolled up blankets, we can adapt with things like that.
We used to make something called a sweetie. I'm probably showing my age here now, where you'd get like a blanket and you'd roll it in a sheet, and then you'd put that at the bolster at the end of the bed and you'd tuck the sides in, and that would stop someone sort of sliding down. You could use it to raise their ankles.
Why is it called a sweetie?
Because it looked like a big sweetie, you know, like
like a bits. Yeah, like okay, with you. Sorry.
You know those diamond sweets and the quality.
Yeah.
Oh, okay. Next question is from Katie. Hi, Katie, if you're there. My question would be: is there an alternative to sleeping in a chair when a client refuses to have a bed downstairs and cannot functionally do the stairs? Is there any other option / equipment? If not, what is considered the safest backrest, recline / tilt in space position and cushion for sleeping? I think we probably have a really good solution for that one.
Yeah, and I think we take a step back and think about why doesn't that person like sleeping in their chair? Before we, you know, jump. While sleeping in their bed, why they don't like sleeping in their bed. What is the root of that problem? You know, it might be that it might be a comfort thing. Right.
Well, as we said as well, we were chatting just before this session started. We were saying that there's so many elements to why someone might sleep in a rise recliner, and it's not just the mobility issues. It's the comfort. It's the maybe poor mental health.
I think it's that maybe that anxiety that you need to get out and go to the toilet, and then you can't get there quick enough with you getting out of the bed. It's a lot easier, isn't it?
It's that fear of falls as well.
In a riser recliner, you can quickly get out with less effort as well.
Yeah, for sure. And I think this particular client that Katie mentions is that their mobility is not so great, so they cannot climb up the stairs. So I know we've had a very successful case, haven't we? Was it in Monica when she was unable to get up the stairs as well? Maybe you'd be better telling that story, Jane.
There's a lady that we've had who had she had issues with her legs. They were quite edematous. She also had diabetic neuropathy, so her legs are very, very sensitive. So getting her legs lifted up and dragging them across the bed was quite a lot for her. And a lot of people don't want the bed in their lounge as well. There's a bit of a stigma thing, isn't it? You know, having your bed in your front lounge brings that disability to the forefront to everybody that comes to see you, doesn't it? Really. But with her, then we took along the Ascender, one of our products, and tried her with that, and that meant that, you know, she was able to elevate her legs. But I think also what it did was it gave her periods of good quality sleep. For this lady, she was sleeping in her chair and not getting good periods of sleep. So I know what it's like if I don't get a good night's sleep. I'm a bit cranky, I can't function as much. And I think we need to think about sleep as an activity of daily living. As you know, as OTs, we need to look at that as an activity, because those people that don't get enough sleep, they are going to struggle during the day with all their activities. So for this lady, we put the Ascender in her front room, and she did periods of sleeping in her chair and periods of sleeping in the Ascender, and gradually built out the length that she was in the Ascender. So that really worked for her.
We actually have the Ascender here. We might even, do we want to zoom over to that just to kind of a very, very quick little demonstration.
So this is Ascender. If you haven't seen it before, we designed it initially for people that were struggling to get legs into bed. it's usually for people. So what's something that I learned is when I was a product specialist, I would always walk in with the occupational therapist or with the clinician, and then they would start arguing with the patient, say, "Oh, you're sleeping in your chair again, aren't you?" And I always wondered why is that happening so much, until we sort of brought this product out and I sort of found out more. Some people struggle to get legs into bed. They may have a carer in the evening to get their legs into bed, but then when they're get up to go to the toilet in the night, they had no other option but then to go back and sleep in their riser recliner, right? So with the Ascender, it will look like a chair in this profile, but it is a bed ultimately. And the thing that I like is when the leg rest comes out from underneath. So when I come to enter, I've got two handles just here so that I can sit, and then the leg rest will come out from underneath. So first of all, it goes into tilt in space. So that means that pelvis below knee, so I'm not going to slide forward, and then the leg rest will come out from underneath. Really popular with Parkinson's, isn't it, Jane?
Yeah.
Because it's not so much sometimes lifting the legs against gravity with Parkinson's, it's that lateral movement getting the legs into bed. So from here, one button press will come straight into a lying position.
Yeah, I think those people that have got that poor core stability, they've got to hold themselves up on the side of the bed in that sitting position as they lift their legs in. You know, sometimes that's quite difficult to manage. We'll leave you there then, Chris.
Yeah,
for the rest of the
talking about good
podcast.
night's sleep, I had a terrible night's sleep because my 2-year-old got in my bed. So it really is important.
Yeah. And I think it's setting that environment up for a good night's sleep. And if you're going to be on your phone just before you go to sleep, that doesn't help, or any sort of screen. So it's setting that environment up.
Yeah,
Sleep
definitely.
hygiene.
Sleep hygiene. And
we did.
And Jenny did a brilliant webinar on that one. That was, I took some tips away from that.
Yeah.
And as I mentioned to you yesterday, I had a bit of a Zen day, so self-care day, and
Yeah.
I put the phone away before I went to bed, so just to improve my sleep. So I think we can all take away from that one. I think
Definitely.
Yeah. Just moving on to the next question then. This is coming in from an anonymous person. So I wonder if any kind of pressure relief overlay would be recommended on a riser recliner. If a patient is sleeping in one, or what factors might impact a decision to provide an overlay? Sarah?
Great question. So I like to simplify things. So I always start with what mobility that person has. So if you can get someone just to kind of lean, to offload if they've got good upper body strength, anything like that, and give them that advice, that guidance of why they're doing it. To be honest, we are very clever creatures, and our bodies, our discomfort will make us do that anyway. If you haven't got that mobility, utilize the mobility in the equipment. So whether that is a bed or a chair, utilize the different angles, utilize all sorts of the leg raise, all of that thing to get that. I don't want to say well, it is repositioning.
Yeah,
it is. You're doing that different angles, and you're pushing, you're redistributing the body's weight and putting pressure through various parts of the body. So can the person move? Can the equipment move? And then that's when I would start thinking about equipment, as in an alternating cushion or an overlay. The things with overlays is it can cause more things like shear, because you've got the whole overlay going over the whole thing. They're not strapped, they don't strap in very well. Obviously every person is going to be different, but what we do know, and especially with our chairs, we can fit the chairs around the body so we can get that pressure redistribution better, and then we can put a cushion within it. The back of the chairs with the waterfall, thank you. We can adapt that so we can sink into it. You want your patient to fit into or onto a piece of equipment like a puzzle piece, really. And that way we can better manage pressure. So overlays are there, and they can be useful, but they can cause additional problems. But does that answer?
Yeah, no, that's great.
I think with most riser recliners, you don't have like integral pressure care, right?
No.
So you might be left, the only option you've got is with an overlay.
Yeah.
I would just say with Accora's seating though, just try and avoid overlays at any cost, because because you're pressure mapped on the seat anyway, you can integrate the cushion, you're pressure mapped on the tops of the armrests. The backrest is not pressure relieving because it's not got like a foam. The wadding isn't pressure relieving, but it's still got that vapor permeable 4-way stretch material. So that's going to be better than nothing, right? And I think
Chris, maybe you want to just show people how to actually insert that cushion.
Yeah, absolutely. Can you come over to this one here? Which way am I going? This way. No, that's
I'm going to go that way.
Good. Sorry, it's reversed on the screen there. So when we talk about the overlay, if you've got a chair that's just like a normal cloth material, you haven't got any pressure relief, sometimes, like Sarah was saying, that might be an option. I think the benefits of having an overlay on this chair are going to be far outweighed because of you've got the built-in pressure care, right? So this is the 4-way stretch material we were talking about, with pressure relieving with visco foam underneath the leg rests for the calves, tops of the armrests, and then the seat cushion as well. If you've been on a Accora training session before, you've probably suffered me going through this before anyway, but in all of our chairs, so whether it's an old chair, a new chair, current chair, all the chairs, future chairs, they're gonna have this visco foam cushion and the vapor permeable overlay as standard. So even if it is an old model, it will still have this in here. And then we've got 2 sections at the back that is, if it is an air cushion, an alternating air cushion, which requires pipes, they can come out the back and be plugged in the back there as well.
I think, so it's an Accora chair, we can do something within the chair, but it's obviously those third party riser recliners where you want to put something on top.
Yeah.
If that person's in there a long time.
Also, with the back, the backrest, whichever ones you have, just don't be too shy in removing the stuffing. You want to you want to, as our colleague Jenny used to say, you want to take out a bin bag full rather than a Tesco bag full.
The black bags,
The black bags, yeah. So I'm going to make a mess now, but take out the stuffing. If you have someone that's sitting on the backrest and it looks like they're bouncing off, that's not going to be good for their pressure. So take the stuffing out. You can take out as much as you like. I pop it in a bag because I don't like waste and I don't like mess. Pop it in a bag and actually hide it underneath the back of the chair. I won't make a mess.
So any sort of deformities that they've got in their back profile, you want to accommodate that in the back of the chair. So, you just want to, I kind of think it's like making a plasticine model. If you look at someone's back profile, if you were to put it into a piece of plasticine, it would leave an imprint. And that's what I'm trying to create in the backrest for somebody to make them, really immerse into that backrest and spread that load around.
And give them that comfort as well.
Give them that comfort.
And for sure. Now, there's been a lot of interest in the Ascenda, so if I'd be coming to you, Chris, for a lot of these for a lot of these questions. So, can people have payment plans to help purchase?
We don't, unfortunately, do payment plans. No.
There is a great cost calculator, though, isn't there, to kind of highlight
there is, yeah. I think so. With Accora, we are like specialist seating, and it's like profiling beds, right? So the majority of the customers that we see and work with is NHS, local authority, that sort of funding route. The Ascenda is the first product that I've seen since I've been here where there's actually quite a lot of retail interest in that. So like Parkinson's groups up and down the UK have been really interested, and like the self-funding route has been more interesting. So this is like the typical person that would use the Ascenda. They would, if they're struggling to get their legs into bed and they couldn't get on with like the dog lead leg lifter, like the inflatable leg lifters didn't work because it gets their legs up, but then the lateral movement into bed. The issue would be then is after you've got like a low level bed or like a floor bed, your next option, so floor bed, couple of grand, your next option is like a 10 to 12 grand turning bed, right? So Ascenda, it sits in the middle of there. It's 2,750.
You just answered one of the questions.
Oh, is that one of it? Okay. Sorry. So it was that. So I think about it. My mum, she wouldn't have a link to this. Sorry, I just got worried. I got worried that she's going to be listening then. My mum's getting to that age now where she's like, struggling to get up from the sofa, and I watch her struggling to get up the stairs, right? And when we released this, I thought, do you know what? A 10-12 grand turning bed is completely out of mine and my brother's scope. We wouldn't, if she was struggling to get her legs into bed, we would not be able to get that for her. Whereas an ascender, me and him could probably work together and get something like that. So unfortunately, it's not payment plans, but it's, you know, it's not.
It's quite a reasonable.
And we'd still come out and do that assessment, wouldn't we? So if
Yeah.
your mum rung up and said, "Oh, my son's told me about this, so I'd really like to give it a try," we would still come out and do.
I'd hope she'd come to me first before calling you, Jane. But
what I'm saying is, we can still do that assessment.
Yeah, absolutely.
So rather than. We've all been out to patients, haven't we? And they said, "Oh, I've just put in a level access shower," and you know, the builder from round the road has put it in, and then it's got 3 steps into the shower, and you think, "Oh no, why did you waste your money?" But we can still give them that trusted assessment.
Well, we do offer trial. Am I right by saying we?
Trial,
14-day trials, and
so that's something that people could try if they're not 100% sure on it, to try it for the 14
And
days.
I think the reason we do the trial is for those people that are struggling with getting in and out of bed. Those issues are happening during the night, aren't they?
And you don't
so
know
us coming
until...
around for a 1 hour assessment is really not going to truly see if it's worthwhile. So yeah, we can do a 14-day trial, I think it is, to see if they really
but it can still be with clinician involvement, right? You can still have an OT out, we would still meet the OT, we'd do the assessment. It would just mean that the funding stream at the end, instead of us sending the OT the quote, we would send it to the patient or patient's family.
Some of our product specialists are OTs by background as well, aren't
Sean,
they?
Sean
in the south and Louise up in the north.
So
they're getting that quality assessment.
It's brilliant. And I was going to add something there, but it's off topic. So
but for those people that are doing the traditional route through specials panel, then it's obviously giving clear and concise clinical justification when it goes to panel, so that then it can get funded as a special through panel.
Just remind me, I know there's 2 different types of mattresses and 2 different types of weight limits for the Ascenta. Just remind us all.
The mattresses are heavily linked to the weight limit. So you've got a 25 stone mattress and a 35 stone weight capacity mattress. So the overall weight capacity of the Ascenta is 35 stone, but you've got 2 different types of mattress, because if you imagine a higher weight limit mattress is denser foam, isn't it? So that's going to be a lot firmer. So if you're towards the lower end of the scale, if you're sitting on a 35 stone mattress, it's going to be a little bit firmer. And there's 2 types of mechanisms as well. So you can use it as a dual motor and a single motor. So single motor means that the backrest and the leg rest work together. Works really well with Parkinson's because they're sort of linked. It's got that sort of seamless flow from sitting into seating. But the more popular one is dual motor, isn't it, Jane? People want to do a little bit of legs, a little bit of back, a little bit of legs.
Sorry, I was going to say, you're going to talk about your...
No, I was going to say I saw a lady in Suffolk, and prognosis, she had really bad arthritis in her hips, and she'd been sleeping in a rise recliner for a long time, so she'd got that limited range in her hips, right? We tried it on where it was linked, and it just sort of brought her to a bit, and she went, no, it's uncomfortable. So we put it on the dual motor, and she got it to where sort of her limitations were, and then she's done the leg rest after.
We've had people who have breathing problems is a key. The reason they don't sleep in bed is because when they go flat, that they can't breathe, so they can obviously play around with that system as well to get it at the right back angle, and then the legs to come up.
For sure. I mean, obviously the weight capacity of it is 35 stone, but there is a question around bariatric version. We don't yet have a bariatric version, but maybe
it's
in time.
At the moment I think they're looking at developing it at the moment, so it's gone through quite a few iterations, isn't it, Jane? So they've changed quite a lot of it. One thing we didn't consider is when it went out for clinical trial, we didn't have anything to hold the quilt on.
No, that's right.
And then the first bit of feedback was, hey, I'm getting up to go to the toilet in the night, I put the blanket over and it's on the floor, I can't reach it. So we've got like the clips and the pillow clips and stuff.
And I think that's where we get all the feedback from. We get feedback from you guys as OTs, but also from the service users themselves are coming up with problems. And we've changed one of the handles on it because it didn't work for one gentleman who was doing sort of a transfer from his wheelchair pivoting onto the Ascender. He just needed the handle to go vertically so he could grab it and pull himself round. So we can do those one-off changes, but it helps us develop the product to make the best
even further to meet the
needs
of many different types of people and different needs. And then I suppose there's a question from Anna. Excuse my pronunciation now. Anna D. Is this chair height adjustable for carers? And I would say I'm going to go to you for that one, Jane.
So the ascender, is it height?
Yeah.
Yeah, when it's in that flat position, there's no height adjustability like you would on a profiling bed.
Yeah.
So you need to weigh up the risks if someone was providing any sort of care to that person in the bed. They're going to be not a very good angle for their back, and there's going to be a risk there.
It's not really for people that are. It's people that are ambulant, semi-ambulant. It's to sort of keep them on their feet as long as possible, right?
Promoting that independence.
But it's thinking about that future proofing, isn't it, of equipment? You don't want it to go out there, and then you know that someone's needs are going to deteriorate, and then we've got to try and get that back, and it's hard to get equipment back once people have got used to it and they like it. So those people that are, it's really predominantly those people that are more mobile and want to maintain their independence.
Yeah, for sure. And I think as well, when we think about carers, if we think about the Care Act, we have an obligation as OTs when prescribing equipment. We need to think about the carers and are we meeting their needs and reducing the risk of harm to them as well.
We might reduce the carers' risk because they're not having to lift someone's legs in and out of bed. So we're reducing the risk that way. But then obviously we don't want them to be leaning over a lower bed.
No, for sure. No. So there's another question from Falcon. Do the armrests come off that sleep chair? So the
sender, they don't know. They are detachable, but it's more for like transit and sort of set it up. But
I think a few people have mentioned about chair. So we're trying to avoid the word sleep chair or bed chair because it's a bed.
And it's we call it riser bed.
So we've been toying with two things: is a riser bed, but then that also it lends itself to riser recliner. People then start calling it a chair bed. So then Sean said, "Well, I'm calling it the independent transfer bed." That's a bit of a mouthful, isn't it? But we're trying to make sure that we're highlighting that it's bed rather than
and I think the reason we're not promoting it as a chair is because it doesn't have that postural support that maybe a chair can give you. And because it's the width of a normal single bed, it's going to be too wide for people. And we know that if we issue somebody with a wider chair, they tend to lean, don't they, over to the armrest, or a chair that's too deep, they tend to sort of slide down, going to sacral sitting.
If we're marketing it as a chair bed, we're then telling patients you can spend 24 hours a day in this, right? Where we're trying to promote independence. It's not really what we're after.
Trying to promote independence, trying to promote people getting up and moving. I know, Sarah, I always love when I'm in your training sessions because you always say put the chair to the other side of the room or sorry the table
to the other side of the room.
People need to get up and move to get their
and just that simplified thing of getting from a chair to a bed is movement. And I know people do struggle with that. But it's so important that we, for your mental health, for motivation, and just, not having everything. We've all seen patients that have got that table with everything on it for the day, for the year, everything.
And the only movement they're doing is this, isn't it? It's like a repetitive struggle.
But because it's a struggle, but actually I want people to not struggle. I want them to keep doing it because you're going to improve your muscle tone or at least keep it as it is rather than it deteriorate. So the more we move, the better it is, even if it is a struggle for people. I'd want to keep promoting
definitely
that. One of the blogs I wrote for this quarter was looking at transfers in and out of the riser recliner chair, and I sort of popped in the question about, do riser recliner chairs make people less mobile in a way, because there's an element of deconditioning because they're not using their muscles to help with that sit to stand, they're using the chair to help them. So how can we stop that deconditioning? Again, it's getting people to move, it's maybe getting them to, if it's on a rehab program, it's maybe getting them to get the chair not as high each time, so only come up a little bit so that they can then use their muscles in the sit to stand. So to stop that deconditioning from happening.
But it's that old saying, isn't it? If you don't use it, you lose it.
Exactly.
And it's so true. So true.
And it's about, when we're prescribing as OTs, prescribing that equipment, it's about that clinical reasoning as well, and not over prescribing, because we want to keep people independent and promote independence, keeping them up and moving. If you don't use it, you lose it.
Exactly.
To that question though, armrests do come off.
Oh,
but not for like it to enable a lateral sliding transfer with banana board. I would say so.
Yeah, they're not. I suppose they're not. You can't put full weight into them either.
No, and then you've got to rely on the carers to put the armrest on and off, and probably wouldn't recommend so.
A lot of questions about the Ascender, which is fantastic. But if people do have some more questions, please do just pop them into the chat. It'd be great to get a few more questions. Going back to the Ascender. I mean, we've obviously mentioned about the riser function and maybe to support carers, but how high does it rise in standing? How high does it support?
Can we go back there? Because I didn't actually show that part. So when we come out of lying, it will come to neutral. So the height of the Ascender is a 16-inch from floor to ceiling. My cut off, Sarah.
Yeah, just a little.
Am I headless?
Yeah.
So someone that has a sort of 16-inch popliteal, you're sort of going to be okay. But I'm 6'3". If I, had a lack of upper body mobility, I did struggle getting up from this position, then it does rise as well. So this is why we called it a riser bed.
Got 2 depth settings on it, hasn't it, as well?
3 depth settings.
3 depth settings.
So you've got 18 inches deep, 20 inches deep, and 22 inches deep. So that is this part that we're showing just here. And I'll show you with the rise, it will come up quite far. And to be honest,
I think that's why we put the handles on, because people were feeling a bit unsteady.
But yeah, this is it. I mean, I would probably be happy transferring from here, and I'm 6'3", but it will still keep going, So the maximum rise, I think it will come up to sort of 28 inches, is it? From floor to top of mattress just there. But you can see here, I think most people won't be able to transfer from that position. So it does come quite high. And then horseshoe subframe. So if you were using a stand aid, not really the ideal client type is using stand aids, is it? So someone that's going to be independently transferring. But there was one gentleman, I think Tennyson said, he was using a stand aid.
A return, I think.
It was a return,
so and there was he had 2 carers to help him use a return to transfer in and out of bed. And then once the Ascender was put in, they just put the care package down to 1 carer. Because I think the second carer was obviously
that lateral turn.
Yeah, I think the second carer was obviously lifting the legs onto bed while the first one supported it. And then they were able to get it down to 1 carer with the return.
Very good. Chris, you sat down there too quickly.
Am I going back?
You're getting lazy, are you?
No, yeah. I was enjoying a sit down, to be honest. Go, what have we got?
But there's a question in around the feet. So Emma has asked, the feet looked low. Do they go horizontal? Go to the horizontal?
I'm going to have to bring it all the way back down now, aren't I? So there is slight hill slope, isn't there, Jane? With this anyway.
Yeah. Which I, as pressure point of view,
and sorry, we'll double up some questions here, because there is another question in around the level of pressure relief in the actual Ascender too. So maybe bring them all together.
Yeah, let's look. I'll get back onto here and sort of show people how it is, but there is a hill slope at the bottom of the Ascender. We can get it horizontal, so we have got some ramps that will then mean that the feet can be horizontal if you need that, but as standard it does have the hill slope built in. And the pressure care, Sarah, is going to be the same as like a standard visco foam.
Standard visco foam mattress. Yeah.
So it's gonna map very similar to how a normal hospital mattress or visco foam mattress is going to be.
It's a 2-layered system, so you've got a memory visco foam top layer and then a standard foam under to support your weight.
Chris, will we make you a cup of tea?
Do you know what? You said don't lay down, you're getting lazy. I'm just going to stay here now for the rest of the webinar. So you can see when we get to here, so it's very observant. Someone said you can notice it goes slightly low. There we go. And then we can use backrest as well when we're here.
So from a pressure point of view, I actually like the fact that it's slightly sloped, I guess, because it does take the onus off of the pressure off of those heels. And as we know, the heels are really vulnerable. And for the people that we are looking at using this, actually I'm happier that it has got that slope to take the pressure off. Yeah.
Can I come back, Nicola, or do you think we'll be?
Well, I'm loving all these questions around the Ascenda and what it offers. I mean, I would just highlight again that I know we've mentioned it, that we can do those free assessments as well if you want someone to come out to support, and we do offer lots of face-to-face training too. So if people want to get some more details or some more training or upskilling on the Ascenda, then we can definitely arrange that for your teams. So, you know, you can definitely contact us after this session if you wish. But I suppose there's another question in around the height. So what height ranges are suitable for so the client height? So obviously you're 6 foot, I think 10 or something, isn't it?
No, 6'3". I would say people, it's a 16-inch popliteal at its lowest. I think you have to be at least 15 inches of popliteal height to be able to get up and back on the chair. We've had it with like 14-inch and 14.5. It's a bit more of a struggle. So I'd say 15 inches and above would probably be best.
Yeah, it's just that people just can't get their bottom far enough back, and then they're perched on the edge of it, and it's not in a good position, really.
Yeah, brilliant. I'd say, you know, as I say, if you have any more questions in and around the Ascenda, please do get in touch with us. Stephanie out there, she's changed the subject, so thank you, Stephanie.
Well done. I kind of feel we didn't want to do too much of a product pitch, really, did we? We were looking at the clinical stuff about sleeping in a riser recliner chair.
Yes, for sure. So we're thinking about the Solus. We don't have the Solus here with us today, but is the tilt in space of the Solus chair safe to use for someone who has heart failure and sleeps in their chair?
So again, it depends completely on the extent of heart failure. Definitely work with your MDT, your teams, your lymphedema teams, your heart failure team, and they will have a dedicated heart failure nurse to look after them. It's again, I said earlier, things like compression and getting the swelling out of legs of those who've got heart failure. It can be done. It just has to be done controlled, under a controlled manner, because you have to feed that fluid back up to get the circulation around the body, but it has to be done slowly. So the tilt in space you can utilize because you've obviously got that angle, but it's actually the leg elevation that you want to be thinking about. The tilt in space won't really have a massive effect on it, so the tilt in space is absolutely fine. It's how much of the actual knee break,
leg rest,
the leg rest that
you might want to do a graded approach of that, mightn't you? No, don't go for the full extended leg rest. Maybe just, you know, a couple of nights a little bit up, and then the next night a little bit more, so that the body kind of gets used to that. The heart gets used to that. And it
hard
also, work that it has to do.
Definitely. And the patient will tell you if they're struggling with breathing or anything. They will obviously let you know. Give that education to the patient. So if they're raising their legs too much and they're feeling that fluid go to their chest, then they need to be bringing the legs down. But yeah, it's a really, really difficult thing and
tricky one to answer.
So tricky, and you know, it's a horrible.
Again,
scenario.
It's when you have that MDT approach, isn't it? And Tanya is asking a bit of it's a long one, so just give me a moment. And so Tanya has a client with Down syndrome and learning disabilities. He mobilizes with a walking frame. He has a few comorbidities as well as arthritis on his spine, causing him to experience neck pain. For this reason, he has been sleeping in a dual motor riser recliner for the last few months, and he declines sleeping on his profiling bed because he reports he finds the bed uncomfortable, causing his neck pain. How could I encourage him? First question, how could I encourage him to sleep in his bed? And then second, he doesn't have any pressure sores. However, how can I make it safe for him sleeping in a riser recliner in the long term?
There's a lot to unpick
Yeah.
there.
There is a
question. That is a great
That
question.
is a great
The-
question.
the-
Really good question.
So yeah, you've got to unpick all of that scenario.
Yeah.
One thing I would be kind of a go-to easy win for me in a way would be get a bed that would go into that, I always get it wrong,
Reverse Trendelenburg.
reverse
Yeah.
Trendelenburg, and get a bed with that function, and get that bed in the position that he sleeps in the chair. So then you've replicated that, and then adjust it from there. So that would be my kind of easy win to give him that reassurance.
Yeah, playing around with a position that's going to be comfortable for him.
Yeah.
Obviously, he's got some problems with his back and his spine. So can we put some pillows in to support that?
Yeah.
And
Maybe pain management.
Yeah.
Re-looking at pain management.
And I think it's going back to that webinar that I did. I think that was in end of January. I did in around sleeping in a riser recliner, and actually, looking at that person as a whole, and thinking about, if they have that capacity to make that decision as well, then it's important to go with that, because people can make unwise decisions. So if that's their choice as well, we need to support that.
As long as they've got the education.
As long as they
of
have
what
that
could
education.
happen.
Highlighting all those risks, with those red flags, and giving the power to that person. It might be not sit so well with us, but actually, we need to care for our clients and giving that advice.
Someone has the capacity to make that decision.
Yeah.
Obviously, you've got somebody here with Down syndrome.
Yes,
So obviously that
And
might
learning
add a
disabilities.
complexity
Yeah,
to it.
for sure.
How willing are they want to change?
Yeah.
Do they understand the consequences of,
Yeah.
if I'm sleeping in a chair, what could actually happen?
Yeah.
You might then have to do something that's maybe more in their best interest,
Yeah.
because
Definitely.
they're not making that, they can't
Yeah.
make.
And
wise
communication is so
Yeah.
important as well, especially for someone with learning disabilities. And
Yeah.
how is it that we're actually communicating that across? Is it are we coming down to their level
Exactly.
and
Could we use
explain it in their
pictures and
terms?
things,
Use pictures,
There's-
maybe a different way of form of communicating.
Definitely. There's some really, really good guidance out there, seating guidance at a glance, by the Society of Tissue Viability. We can put a link in, maybe at the end, to
Definitely.
give you that. Really, really good guidance, and you've got a leave piece, sort of like a 2-page document for patients, for carers, for family, and it's just a really simple guide, but it shows you all the things and talks about all the things that we need to take into
and it might be not associating, what is the reason why he doesn't want to sleep in the bed. Maybe it is just pain, but it might be there's other things going on. So could you replicate that position in the daytime, doing an activity that he likes, for instance? So he's sitting there doing something that's meaningful to him.
Engagement.
I know if I can't sleep, I get in the bed, I'm thinking, I've got to go to sleep, I've got to go to sleep. It makes it hard, doesn't it?
Much worse.
Without those added complications of pain. So, thinking activity in the day to get in that seated position in the bed, the bed then becomes a good place, doesn't it?
And it's going back to that sleep hygiene as well, isn't it? How can we optimize that environment to support good sleep?
Oh, good luck with that one. I'd
I
like to hear
know,
how she gets on.
What's the second part of that though? Is how could you?
So firstly, it was how could I encourage him to sleep in a bed? And he doesn't have any pressure source. However, how can I make sure it is safe for him sleeping in the riser recliner in the long term? So again, it's just having that holistic approach, isn't it? And unpicking it and
So
looking
anything
at.
you've changed, like would you put, if he's not got any pressure source, he's been sleeping that, right? It's monitor.
Yeah,
I suppose you wouldn't go and put a dynamic air cushion or change the pressure care, would you?
Not necessarily, but if the behaviour isn't going to change and you are going to be in that chair, it is again looking at all of those things, like, is that motivation lacking then? Are we feeding that problem and making it worse? Therefore, we're then going to put them at more risk. Does that make sense?
For sure.
Then weighing up all those risks and which ones can we minimise?
Yes.
So we might be able to minimise the ability to move by moving the chair every couple of hours, mightn't we? And make sure we've got the right surface that
I think it's in that webinar I did. I can't remember fully the slide I did, but it was about actually looking at that person holistically within that chair. How is it that we can support their pressure relief? How is it that we can support their posture? So making sure that we have the correct backrest, getting that tilt right, educating on repositioning, readjusting, using the tilt, thinking about their diet as well, making sure that they do have a good diet.
Hydrated and
keep hydrated, yes, yeah. It's just about that education, right? Highlight those risks, and if they continue to stay in that chair, then how can we support them fully in that chair? Is it about getting that table just beside them so they can reach and have a drink independently? Do they have someone there to call it in the environment to support them, etc., etc.? I could go on all day.
There's so much.
There is. And would you believe, guys, we've been chatting for like 50 minutes already. It's 5 to 12.
Wow.
Yeah. If anyone has any burning questions, please pop them in the chat, and we can definitely maybe run through another one or two. But just please be reassured that we will be sending out the recording to you all, and any resources that you need, please just get in touch with us. The slides will also be sent out to yourselves, and I would encourage you again to, if you're not already signed up to our monthly resource pack or newsletter, I should say. You get a lot of fresh information from that, so do sign up to that newsletter. Not sure if there's any more questions in the chat, but I suppose to my colleagues, any kind of anything that stood out to you within this quarter of sleeping in a rise recliner when we've looked at that resource pack, those blogs that you've done, maybe chatting to your colleagues, anything that we've learned this quarter around sleeping in a rise recliner?
Think every scenario is going to be different, and I think don't worry too much. It's going to be that unpicking, and you can't change these things overnight all the time. So I think you just said it, it's picking those things that you can adapt, like improve nutrition, and educating, utilizing tools that we have got out there, utilizing our guidance and self-help sheets, and doing the bits that you can. Even if it's a small change, it will make a huge difference. And just reaching out for support to the wider team, to us, to the clinical team, to you guys for support on the equipment. Use us as a resource as well.
Yeah, for sure, definitely.
One thing from my point of view, if it's related to the product, if you have got someone sleeping in a rise recliner, one of the best questions I always get is, how long do your chairs last, or how long should it be? And I go straight to your guidance here. It depends. It depends. That's Sarah's favourite lyric.
That's our next podcast. It depends.
It depends, yeah. And one thing to consider is, if you have got someone sleeping in an Accora rise recliner, look, they're not designed for that. We would never suggest someone do it from a product point of view. However, we do know that people can sleep in a rise recliner. If you've got someone sleeping in it and spending all day in it, it's going to be getting double the amount of usage. So if you have a chair that's 3 years old, but they've been sleeping in it during the day, they've been sleeping in it at night and then using it during the day, that's not a 3-year-old chair. It's a 6-year-old chair, because it's had double the usage. So that's one thing I would say to consider when sleeping in a rise recliner.
I think when I look back to my webinar and when I did the webinar on sleeping in a rise recliner, it was around, I know you and I, Jane, had a bit of a conversation around this and thinking about the unconditional positive regard. So, hearing that patient and actually remembering that patient is at the forefront. And
I think it's, what is that patients allowed to make that choice, aren't they? And what's important for them, the fact that they feel that they can get out easily and go and do tasks, that's better, and that's what they want to achieve,
a good quality of life. And I think the most important thing from a clinical perspective and our responsibility, if we were to think back to our standards and guidelines, etc., is making sure that we document it and make sure that we're clear in that and concise.
That we've had those conversations, we've presented all the risks, haven't we? And we've documented that for them. So definitely, I think it is, letting that, remember that person's the center, isn't it? Sometimes we get hung up on this is the solution, but what does that person actually want?
What do they want? And if they have that that mind to make that, then that's okay. We're meeting their needs. Guys,
that flew by.
Wow, I hope everyone's enjoyed it as much as we have.
It goes so quickly, and I think this session has been really, really positive. We got some really good questions in prior, and some really good ones through the chat. And this is something that we're going to be continuing to do. So please do come back to our Accora Clinical Corner through our Accora Academy. And we love it, and we hope you guys love it. So we really appreciate some feedback on this session as well. I know there will be a link that's sent out.
If there's any topics,
that you want to cover, and you know, if you do need some additional training in around the Ascenda, you know, I know we did a lot on that today, but please get in contact with us. And yeah, we love to help. And yeah, thank you so much, everyone, and we hope to see you all again soon.